Good morning, everyone. Thank you for joining our weekly Cancer Center Grand Rounds. And we have really a special session for you today. And I think that's also evident by the way people are trickling into this session very quickly here. Our today's topic and today's speaker needs essentially no introduction. So if you do not know what COVID is or who Dr. Poland is, you must have been living under the rock. When I think of Dr. Poland, I think of vaccines, and he has a long and illustrious career. And we have recapped on a couple of occasions already so far over the last 8 months or so. But I'll suffice to say that he's an endowed professor of medicine. And has spent a large part of his career at Mayo Clinic in Rochester. He was awarded a very prestigious award of a distinguished investigator at the Mayo Clinic in 2013, which is given really to people that have dramatically impacted not only scientific discoveries, but also patient care. He has been in the role now for quite a few years as a director of the program in translational immunovirology and biodefense in the Department of Medicine at Mayo Clinic in Rochester. He's a professor of medicine and infectious disease, molecular pharmacology, and experimental therapeutics. And he is the director of immunization clinic and services at Mayo Clinic. His long list of other leadership and directorship positions is too long for me to go through, as it is to go through his honors and awards and visiting professorships, which are quite remarkable. Given that everybody is dying to hear about COVID and the update on all the variants that we are struggling with, as I would predict that every one of us has somebody or knows somebody who has just had COVID or just has COVID. If we were in person, I would ask for the show of hands how many are currently positive. And maybe that would be an interesting question if we could poll everybody here. But without further ado, Dr. Poland, we look forward to you updating us on this plague that we're going through.
Alex, thank you very much. Let me just be sure you can see my screen. Are you able to see my screen?
Not yet.
Yeah, not yet.
Wonder why. Let's try that again. Now?
That's good.
Now we can see it.
Yep, perfect. It's in presentation mode.
All right, let me shrink this, move these controls. Okay, well, I entitled this, and Alex, thank you for that introduction, and hello to all of my colleagues. You're all over the United States, so good morning, good afternoon to everybody. I entitled this Year 3 of COVID-19, Harsh Truths, Realities, and some Glimmers of Hope. Disclosures, basically all of the Western vaccine manufacturers I provide consultation to, and we've been funded to develop our own novel platform COVID vaccine. Well, my objectives are really to help understand the continuing reality of SARS-CoV-2 and the intersection with human behavior, understand practical aspects of illness-induced and vaccine-induced immunity, benefits of vaccines and infection. I'll start with Sir William Osler, who said humanity has but 3 great enemies: fever, famine, and war. Of these, by far the greatest, by far the most terrible, is fever. Well, the situation is that we are dealing with a novel virus and rapidly changing genotypes, highly kinetic data, irrational human behavior, uncertainty, a continuing surge in morbidity and mortality. And I want to make the point, because people become sort of locked into what they learned a year ago or a month ago. Everything we say is conditional and tentative on the current situation. A new variant could change some of the data that I'll share with you. Well, the reality is, because of that, much of what one knows is likely wrong, outdated, tinged with false presuppositions, and based on belief-dependent realism. That's a term psychologists use whereby people come to conclusion about a topic and data does not change their mind. But I hope we would all agree that the best method of knowing truth for a science issue is the scientific method. And this is often incompatible with what one wants to believe. So the harsh reality is that everything we understand about SARS-CoV-2 is conditional upon time, variant, geography, type of immunity, host factors and behavior, population structures and substructures and levels of immunity, the community burden of transmission, and the interplay among the above. And for those of you that catch the reference, I often say, welcome to the matrix. Well, Alan Jacobs said, relatively few people want to think. Thinking troubles us. Thinking tires us. Thinking can force us out of our familiar, comforting habits. And thinking can complicate our lives. Well, more reality, the story of this pandemic is going to depend upon human behavior and viral behavior. And I think you intrinsically understand we only get to sort of control the first, although it influences the second. And as a result, we will continue to see the evolution of viral variants. Remember, this is the 5th time we've watched this movie, and some will and have developed the ability to evade in whole or in part both vaccine-induced and illness-induced immunity, as well as the value of antivirals and monoclonals. The brutal reality in the US is this: as of Monday, a little over 870,000 Americans have died of COVID. That is 1 out of every 375. Unfathomable that this could be the case in the second decade of the 21st century, in a country with more literacy, more money, more of everything than any time in recorded human history. If you're over the age of 65, 1 out of every 100 people 65 and older have died of COVID. That's equivalent to 42 airplanes carrying 400 people crashing and killing everybody aboard every week for 52 weeks straight. We would never stand for it. US males have lost 2 years of life expectancy. If you're a Black male, 3 years. That's more than since World War II. More deaths than due to the 1918 influenza pandemic. Only 65% of eligible Americans are fully vaccinated. Only 25% of the entire American population is fully vaccinated. Among those that are vaccinated, only 33% have been boosted. And you ask yourself, how is this even possible? Well, because of distorting factors of human behavior, vaccine hesitancy and rejection, regardless of the amount of data. People who are anti-mask based on ideology and not science. Political and economic conflicts of interest. A lack of courageous leadership. We now have an animal reservoir in deer and other animals. The false presupposition of the democratization of expertise. How many times do we hear a layperson say, well, I've done my research, as if that's equally expert? A false epistemology for determining truth, and pathologic cultural narcissism, whereby we live in a me, not we society. Well, Marcel Sandrail, the physician philosopher, said, each civilization, by its customs, its laws, its principles of thought, creates for itself a pathology appropriate to itself. A society chooses its diseases and shapes its own pathological destiny. And that, I would submit, is exactly what we have seen in the US and, in fact, Western society. So what about SARS-CoV-2 variants and the lies we tell ourselves? Well, just a reminder that when we talk about the S or spike protein, this is the protrusion off the virus that in fact gives it its name. So we're going to look at this S protein composed of the RBD or receptor binding domain, which is the S1 component and the S2 component of that. This is where the majority of mutations that impact our ability to protect are occurring. So we're going to talk, because it's basically all of the virus now circulating in the US. A month and a half ago, you would not have believed me, but now it's essentially all of the virus. This was isolated in Botswana in early November of 2021, rapidly disseminated across South Africa and the world. The data suggests that it's about 2 to 6-fold more transmissible than Delta, but a lower virulence compared to Delta. Surprisingly, a much larger, much larger than any variant we've seen, genetic distance from the ancestral Wuhan strain. And therefore, it further escapes both illness and vaccine-induced immunity compared to the other variants of concern, with evasion of the therapeutic effect of at least 2 sets of monoclonal antibodies, but also accounting for significantly enhanced infection of children as opposed to the other VOCs. Don't worry about trying to see detail here. I wanted you to just get a sense of the amount of mutation that's occurred. On the far left side is the wild type Wuhan strain, the Delta strain, which caused so much problem. Look at the number of mutations across the genome of the spike protein of Omicron, particularly in the receptor binding domain. Think of the receptor binding domain as the key, which inserts itself into the lock that we call the ACE2 receptor, such that it can enter into our host cells. So if you look at a top and a side view of that RBD and of the virus, you see the mutations that occurred in Delta and the overwhelming number of mutations that have occurred in Omicron. Likely, this is a recombination event, but also remember that every time we allow this virus to infect another human, we essentially hand it a lottery ticket to continue to mutate and recombine. And among people who have more chronic infection, like those that are immunocompromised, we allow the possibility for co-infection and therefore recombination events. Well, I wish I could see a show of hands to ask, what should we be more concerned with? A variant that demonstrates increased transmissibility, or one that demonstrates increased virulence? So let's take a look at it. Let's take a baseline scenario where a community has a stable number of 10,000 infections. And let's assume that each new case generates an average of about 1.1 new cases, something like what Wuhan did. And that around 0.8% of those new cases would result in death. In 1 month's time, therefore, you would expect what I show here, 129 deaths. Now let's take that same scenario, but make the virus 50% more lethal. The number of deaths goes from 123 to 100, or rather 129 to 193. So that's what happens when we make it 50% more lethal. Instead of changing lethality, let's make the virus 50% more contagious, more like Omicron. Now, after a month, there are 978 deaths, or a 658% increase. That's what exponentiality does. This is where the media has not helped the public to distinguish. They talk about it as a milder virus, and people hear mild virus. But when, even though virulence may be half of what it was with Delta, when you have 3 or 4 times more infections, you actually end up with more hospitalizations and deaths. This is a critical concept. It's why human decision-making always, this is the only time you'll hear me be dogmatic, always human decision-making fails in the face of exponentiality, because leaders are unwilling to make decisions at this point when we suspect exponentiality. So the gray line is the original virus. The red line is what happens if you make the strain 50% more lethal, something like Delta. The orange line is what happens is if instead of increasing virulence, you increase transmissibility. This is exponentiality. So let's look at what's happening as of this morning with COVID in the US since July of 2021. Compared to our 2021 winter peak with Delta, now that we're seeing, and again, this is exponentiality of Omicron, cases have gone up 300%, hospitalizations 115%, and deaths almost 60%. So exponentiality cannot be controlled because of the biases and issues surrounding human decision-making. Therefore, this is no longer controllable by testing and contact tracing. In my mind, that's off the table. And there are now 3 ways in which this pandemic can be controlled. A hard lockdown with mandatory masking and distancing, and culture has rejected that. The virus mutates to be less transmissible. There's no evidence for that. In fact, quite the contrary. And we have a high efficacy vaccine that's widely used, and the culture has rejected that. Ergo, this cannot be controlled. So one other glance at exponentiality so you really grasp this. Let's look at 2 scenarios. Assume 10 cycles of transmission in a naive population. Scenario A, modeled to look more like alpha, leads to less than 10,000 infections after 10 cycles. Increase that R0, the transmissibility, to 6, and in those same 10 cycles, you get 60 million infections. That's the power of exponentiality. Well, George Bernard Shaw said we learn from history that men never learn anything from history. And again, I could tear my hair out if I had any over this. We have watched this movie 5 times in 2 years, and we seemingly do not learn. So what about vaccine efficacy and effectiveness? Well, this is a very complex interplay. There's no way to reduce this to a headline. And this is what the public and many providers don't understand. This interplay involves host characteristics. So my answer about vaccine efficacy is different based on your age, race, even gender, your baseline genetics, your comorbidities, the particular variant we're talking about at the time, the inoculum size, the portal of entry, which vaccine and in what order you got them, the time since your vaccination, and even geography. Vaccine efficacy is a gradient of protection. Please understand this point. Getting vaccinated is not a on-off light switch. It is a rheostat. And the reason for that is the vaccines we have against COVID, like all of our vaccines, are much better at disease blocking than infection blocking. The state of your underlying immune system health, which variant happens to be circulating, the community burden of transmission, and the others I've mentioned. So this is a decreasing gradient of protection. The vaccines we have against COVID are spectacular in preventing death, severe disease, and even hospitalization and complications. They are less efficacious against mild and asymptomatic infection and prevention of transmission. When people say to you, well, I know people who got the vaccine but got it anyway, they're essentially advertising their ignorance of this basic biologic fact. Yes, they may have had asymptomatic or mild disease or a positive test, but chances are they did not end up in the hospital. They did not end up with a plastic tube down their airway, and they didn't die. And so to illustrate this, this is a graph that a colleague of mine, Natalie Dean, who's actually now at Emory, created. If you look at the top, this is a vaccine that is disease blocking, but not infection blocking. The value of the vaccine is that you considerably decrease severe, moderate, and even mild symptomatic disease. You really collapse that, though you still have mild symptoms. The vaccines we have are more akin to the bottom. They prevent disease spectacularly well, less so with infection, but still do. And so you're basically collapsing this to almost nothing among the vaccinated. The people who are dying and being on mechanical ventilation are the unvaccinated. And so you really collapse that and decrease the total burden of disease. So why do breakthrough cases occur? Well, for the reasons I mentioned, this gradient of protection, waning immunity, increasingly immune evading variants, the very high community burden of transmission, host factors, and the apparent paradox of increasing cases among the immunized as more and more people are immunized. In other words, when everybody's immunized, the only cases that occur are among the immunized. Even though if we didn't immunize anybody, we'd have, who knows, 1,000-fold the number of compared to the small number of cases we see among the immunized. Other factors, this is looking at antibody levels after an mRNA vaccine simply by age. And you get very different numbers if you're 20 than if you're 60 or 80. What about taking into effect age plus variant? This happens to be the gamma variant. So if you look in the original strain, as I just showed you, we see decreasing antibody levels, i.e., these will wane to a level not protective faster when you're in your 60s and 70s than when you're in your 20s. Now add a variant to it, you further decrement the neutralizing ability of both illness-induced and vaccine-induced immunity. It is a very naive concept to believe that because I've been previously infected, that I am somehow immune. That would be true with measles. It is not true with a non-monotypic virus like SARS-CoV-2. And so what happens, and we see different arcs based on whether you got the Janssen, the Pfizer, or the Moderna vaccine. Over time, the ratio for infection, the hazard ratio, shows a predictable curve. This is, you're seeing waning here. And these curves happen to be adjusted for age, race, ethnicity, sex, and comorbidity. And still this is striking. So what can we say about Omicron, and at least what's been most commonly used, the Pfizer vaccine? You see an almost 42-fold drop in the level and neutralizing ability of antibody. Now, it's a little different if you got infected plus vaccine than if you got vaccine alone. The problem is if you survived your infection and what kinds of complications were you left with. So to show you vaccine efficacy against symptomatic disease over time in the US, if you got Moderna, your efficacy against, or your effectiveness against symptomatic disease dropped from 90 to 60%. If I could extend this, you'd be down to about 30% to 20%. For Pfizer, you dropped from about 87 to 40%, down to between 0 and 20% now. J&J from about 86% to 13% to almost no efficacy now. What about those same timeframes, but the far right column against death in people less than 65, and the far right number is people over 65. You see a drop, but much less significant, except for J&J, than efficacy against symptomatic disease. So even with time, people who are vaccinated retain excellent disease, severe disease blocking ability, but not infection blocking ability to the same extent. Let me show you in different ways. This is Pfizer vaccine, and this is time on the x-axis, and this is vaccine effectiveness on the y-axis, and the different colors represent age. The 12 to 15-year-olds, they continue to do well. Wanes with time. That's vaccine efficacy against infection. Take the same group of people and look at vaccine effectiveness against hospitalization by time. You see that it is retained. This is the reason to get vaccinated. This is why it's naive for people to say, well, why get vaccinated? I've heard of people who get vaccinated and get infected. What about booster doses? Well, here's the theoretical construct that we as vaccinologists bring to this. So you have a new infection, a new pathogen. You want to quickly build immunity in the population. You wait to see, does immunity wane? We found out that it does. So you rebuild that immunity with a booster. Wait and see, does it wane? We found out that it does. So what do? We will we will have to go to a variant focused vaccine, because the genetic distance between this and the original strain is so great. And that is in an attempt to refocus immunity to the new viral variant. This is our own collective fault. So what happens is, when you're talking about vaccine-induced immunity or illness-induced immunity, it all wanes, all of it, down to the point where you have no or little neutralizing ability. You may well retain immunity, T-cell immunity, that blocks severe disease and death, but not milder levels of disease. So let's look at real world effectiveness data. This happens to come from Israel. And this is looking at, on the bottom in blue, 3 doses versus the red, 2 doses. Remember, Israel was the first country to move to 3 doses. Interestingly enough, though a far smaller country than us, their research and data capabilities are superior to ours. And they make policy based on data, not politics, rapidly. So what do you see? If you only got 2 doses, with time, your risk of admission to the hospital slowly climbed. That did not happen if you got 3 doses. What about severe disease? A minimal, if any, detectable after 3 doses, but still evidence of severe disease in 2-dose recipients. What about death? Well, because you're now including older people with comorbidities, you can't perfectly protect against death, but a dramatically different curve in those who got 3 doses versus those who got 2 doses. So if you look at the current primary vaccine and booster dosing in the US, with Pfizer, we can now go down to age 5. Many of us are hoping that within the next couple of months, will be able to go down to perhaps as low as age 6 months. This is a concern. There are some 5,000 children in the US hospitalized with COVID. The reason being is, unlike Delta, which was primarily lower respiratory tract, Omicron has a greater affinity for the upper respiratory tract. And depending on the age child you're talking about, their airway will be smaller than your little finger. So they get into trouble and require hospitalization at higher rates than adults. So we need a vaccine for younger kids. The dose varies by age group, and booster doses are for, now it is moved down, but for Pfizer after age 12, 5 months after that second dose, we can boost. Same with Moderna, though we use a different dose with Moderna. Same with J&J. For the immunocompromised, they, in essence, get a 3-dose primary series and then a booster. Now, I'm asked all the time about my preferences. So let me give them to you. After your primary series, for a booster dose 5 or more months later, my preference would be toward a heterologous, that is a different vaccine than what you got as your primary series. And that preference, based on the data, would be Moderna slightly edging out Pfizer and much more edging out J&J. If you got a J&J primary, your booster, you're eligible for a booster 2 or more months later. And again, my preference would go in the same order. Now, this could be changed by, let's say you originally got an mRNA vaccine and had a particular side effect or issue, or you come to it with a comorbidity that might change our mind, but this would be my general preference. So let's look at what happens. So this is 2-dose recipients over time. And you can see that with Delta, the neutralizing ability and therefore vaccine effectiveness slowly waned. But look at the difference in waning with the Omicron variant. Same with boosters, whether we're talking about Pfizer, little less so with Moderna, hence my preference location. Now, this is a little more complicated graph, but it gets at this idea, looking at the columns. So the top is Moderna, the bottom is Pfizer, and then the columns are people who were recently vaccinated within 3 months, distantly vaccinated 6 to 12 months ago, distantly vaccinated and survived infection, and those who were boosted less than 3 months ago. And the basic point I wanted to draw out here is that in all cases, whether we're looking at wild type or Delta, we see a decline, with a dramatic decline for Pfizer, anywhere from 6 to 43-fold, with, for Moderna, with Pfizer anywhere from 4 to 122-fold decrease in the ability to neutralize the Omicron variant. A little better preserved if you had distant vaccination and you survived infection. And even better if you got a booster, though this will surely wane with time. So what about vaccine safety? And let me start off with saying there's no such thing as safe, only safer. This is another point I want to be dogmatic about. There is no risk-free decision here. It is the balance. Wisdom resides in discerning the balance of risks and benefits. And you really only get 3 choices, though soon you'll have a 4th. What are they? You can risk getting infected with no apparent benefits. You can have the much smaller risks of a vaccine with major benefits. You can isolate yourself like Howard Hughes did, and that has a whole set of risks. And soon a 4th choice, you could get Evusheld, the monoclonal antibody combination, every 6 months, which is highly effective against hospitalization and death. So let's look at a smattering of these risks. Let's take the mRNA-associated myocarditis. This is much in the news. And again, we're discerning levels of risk so you know which risk to take. You don't get the choice of no risk. If you choose to get infected, your risk of myocarditis is 16-fold higher than if you don't get infected. Let's look at benefits and risk after Pfizer. So let's take the highest risk of myocarditis, and that's in boys 16 to 17, and really we could go into the late 20s years of age. And so these are the myocarditis cases per million. These are COVID outcomes prevented by getting the vaccine. So let's take, I'll just choose the highest, the 16 to 17-year-olds. If you get the vaccine, you prevent almost 57,000 cases of COVID in that age group. You prevent 500 cases of hospitalization. You prevent 170 cases of ICU admission at the cost of 73 cases of myocarditis. Now, what can we say about myocarditis? It's mild, benign, and quick. The vast majority of these will either be undetected or will be mild because everybody's freaked out about it. We hospitalize them. They're hospitalized for 1 or 2 days, may be treated with a non-steroidal and released. No long-term ill effect from this, in quotes. So FDA is requiring Pfizer to follow these myocarditis cases through 2025 to see if there's any long-term effect. Has there been the very rare case of death or more severe disease? Yes, but we're talking onesies, twosies. So we're going to compare now on the far left, the first dose in purple of Moderna versus Pfizer in whatever that is, yellow or orange. And you see that the rates are pretty equal after the first dose. Well, now on the far right, let's look at the second dose. We see a much higher, now we're talking about a scale of 0 to 3 or 4 here, but nonetheless, we see much higher rates after the second dose of myocarditis or myopericarditis with Moderna versus Pfizer vaccine. This corresponds, we think, to a higher dose and more reactogenicity. It also corresponds with higher immunogenicity and protection. What about TTS with J&J vaccine? Well, let's look at those rates per million. Highest rates are in that 30 to 39-year-old group. About 1.3 per million in males, about 10 per million in females. So we've given about 15 million doses. This was as of mid-October, with 47 cases of TTS reported and 5 deaths. So let's try to put this all together. So I'm going to look on the top with J&J in the highest risk female group of TTS, about 8 to 10 per million if you get the vaccine. By contrast, what do we prevent by getting the vaccine? 10,000 cases, 900 hospitalizations, 140 ICU admissions, and 20 deaths. This is why I say, which risk do you want? Do you want to die, or do you want the risk of TTS when that risk of dying is twice as high? What about GBS in males in that 50 to 64-year-old age group? 14 to 17 cases of GBS, preventing 10,000 cases, 1,800 hospitalizations, 480 ICU admissions, and 140 deaths. Which risk do you want? Let's move on to mRNA vaccines with myocarditis in the highest risk group, 18 to 29-year-olds with, let me just pick a mid number, 25 cases of myocarditis if you get the vaccine. If you don't get the vaccine, 9,600 cases of COVID, 300 hospitalizations, 60 ICU admissions, and 3 deaths. Maybe for you, a little harder calculus, but let's at least let the numbers drive our decision, not fear, not what I read on social media. T.S. Eliot said, when we do not know, or when we do not know enough, we tend always to substitute emotions for thoughts and thinking. There are other issues here. It's not just about hospitalization. This is brand new data coming out. Sorry, this should say 2022. They looked at 443 individuals after infection versus a larger number of matched controls, and did a comprehensive organ assessment. And what did they find? After SARS-CoV-2, this is people who survived. These were non-hospitalized. This is mild to moderate COVID. Their lung volume was decreased. Their airway resistance was increased. Left ventricular ejection fraction decreased. Right ventricular function decreased. Troponin and NT-proBNP elevated. Increased risk of DVTs. Decreased GFRs. So there are subclinical, and I think we're going to see a whole spate of issues in the years to come as people age or have another insult, something like what oncologists talk about when they talk about the 2 or 3 or multi-hit hypothesis for why somebody now develops a malignancy. I think we're going to see that with subclinical COVID disease. Now let me show you a study that looked at, these were people that happened to die of their SARS-CoV-2, and they looked at biopsies across the human body, and down on the bottom, the brain. The reddish color shows 1,000 to 500,000 copies of the virus versus blue, which is down to negative and clear. And you look by day, so less than 14 days, 15 to 30 days, more than 31 days along the bottom. And you see ample PCR evidence of infection across different organs in the body, notably, not surprisingly, the respiratory tract, the myocardium, pericardium, and aorta, thyroid, skeletal muscle, ocular tissue, and brain, which tends to decrease, though not be eliminated, as long as 31 days later. This undoubtedly accounts for some of the long COVID symptoms that we're seeing. Now, in people who died, these are biopsies with immunohistochemistry examination of their brain. Basically, what I'm trying to show you is the green is intact SARS virus, the magenta is the N protein. And you see throughout the brain and even brain blood vessels, ample evidence of actual infection in the cerebellum. So what happens next? Are we going to move to endemicity, to more variants, to more boosters? And the question I get asked by the media all the time is Omicron the path to endemicity? Please ignore those people who say yes. They do not know, because there is no way to know. We do not understand the biologic, virologic, and immunologic rules by which viruses become endemic. There's one exception. We know that very high population levels of immunity have a forcing action toward endemicity. And this is what people are getting on TV and saying, yeah, this is how we get to endemicity. That's possible, but it's only one of many likelihoods. Can this virus be eradicated? No, we gave up that right early on because of our human behavior, therefore continued transmission. we now have an animal reservoir. Immunity, whether it's illness-induced or vaccine-induced, wanes, and we're seeing continued viral mutation and recombination events. Let me be bold here to tell you, your great-great-great-grandchildren will be getting COVID vaccines. Just like if you got flu vaccine this fall, and I hope you did, you're being immunized against the 1918 variant. Anticipations, I think that under mutational selective pressure and recombination, we're going to see further changes. And there's ample evidence for that. As I say, we've watched the movie 5 times. Scenario 2 is that it could mutate into a virus with significantly less transmissibility and virulence, allowing movement into the endemic phase. The problem is we have zero evidence for that to date. I'm going to skip by that one. So let's just look at Omicron versus Delta in the US. The risk of bad outcomes is less with Omicron. For children, 67% decrease, basically 70% across hospitalization, ICU, and need for mechanical ventilation, 30% decrease in ED visits, except what's happening. While it's 70 to 50% less likely to cause disease, we're seeing 2- and 3-fold more infection, paradoxically raising the number of cases, 300%, hospitalization, 115% increase, deaths, 60% increased. If you look at protection from prior infection, if you were previously infected, your protection against symptomatic disease due to alpha, beta, and delta was pretty good, but it dropped to 50% with Omicron. Severe disease retained pretty well. So there, we always have to distinguish between, are we talking about symptomatic disease or severe disease and death? How about risk of reinfection? Omicron's associated with about a 5.5-fold higher risk of reinfection compared to Delta. This has been very difficult to get across to the public. With Omicron, vaccine efficacy 90 plus days after your second dose falls to between 0 and 20%. Post dose 3, it rises back up to 55 to 80%, but will wane with time. If we look at healthcare worker study, 44,000 healthcare providers in the UK who are routinely PCR tested every 14 days. Vaccine efficacy against mild disease was essentially 0 by 20 weeks after the 2-dose course. After a booster dose, protection increased to about 70%, but dropped to 50% by about 10 weeks. But efficacy against severe disease after a booster dose was 92% and remained high at about 83% 10 weeks later. This is the argument for wearing a proper mask properly. It's inconceivable we have to make laws to enforce it, but these are the data. I guess I've shown you that already. Vaccine efficacy, as I said, just to show you, because people learn differently, after post-dose 2 for hospitalization, it still remains relatively high, but not against symptomatic disease. All right, let's look at symptomatic hospitalization, ICU admission, mechanical ventilation, and mortality. The S gene drop-off is Omicron. The purple is Delta. And you see that the risk of hospitalization, ICU admission, mechanical ventilation, and mortality is indeed less. It's not 0, but it's less than Delta. Why are we seeing such a surge? Because unlike the case with Delta, we're seeing 3 and 4 times the number of infections. So even a smaller percentage leads to a higher number. So let me summarize here. We have some major issues: willful delusion among industry, government, and the public, in particular, belief-dependent realism, magical thinking, tribal think, and conflicts of interest. My assessment, and this is a slide I wrote in the beginning of November. I knew nothing about Omicron at the time, and my assessment is there was a non-trivial likelihood of a significant worsening pandemic that the US and Europe would not be capable of controlling. Consider, though, that SARS-CoV-2 is controllable with proper masking, distancing, add vaccines, and it is eminently controllable. And yet we have proven ourselves incapable of rationally responding as a society. And I believe the evidence for this is overwhelming. This is one of the leading causes of death now in the US. In various geographic regions, the healthcare system is overwhelmed. As I said, 1 out of every 375 Americans has died of the disease I can prevent with a 25-cent mask and a free vaccine. Current modeling suggests 50,000 to 300,000 more Americans will die of COVID by mid-March. In 1625, 200 years before the germ theory of disease, during England's pandemic with the Black Plague, a theologian wrote this: "Abhor more than poison the wicked opinion that the pestilence is not infectious, that each can do whatever he wants, that avoiding persons and places and diligent use of means for preservation are needless and of no use." Stunning. So how do you manage a pandemic? You have to take into account human behavior and presuppositions. If you want to control a pandemic, you have to have mandatory vaccination and mandatory masking, followed by antiviral and monoclonal development and use. Well, George Santayana said, "Those who fail to learn the lessons of history are doomed to repeat them. Only look at 1918 to see he was right." Or if you prefer, Mark Twain's quote, "History may not repeat itself, but it certainly does rhyme." So no surprise, RNA viruses mutate, especially with unrestrained multiplication. Masks and vaccines work, some better than others. Immunity wanes with time. Vaccines are better at disease blocking than infection blocking. Single antigen S-only vaccines are not optimal. We were unprepared, and I will make one other statement. I believe it will only take a few years and we will again fall back into denial and complacency. I think we foolishly think we understand coronavirus and that the pandemic is over. More variants will come, and human behavior distorts and compromises rational response. So I will stop there, and we have a few moments for questions, and I will stay longer since I went a bit longer to answer any questions that I can. Thank you very much.
Thank you very much, Dr. Paul. And this was extremely informative as usual. And I think judging by the comments that came in through chat and question and answers, people really enjoyed this. For everybody, I know we typically end at 9 o'clock Arizona time. We will extend our discussion a little bit today, as long as people are interested in staying, and it seems like they are. So there was a set of questions relating to the ability to predict what's going to happen to this pandemic compared to 1918 influenza. Where is this going to go? And I think you answered a lot of those. One interesting and practical question is, given that so many providers are getting sick, how do you envision us increasing that protection? Israeli data that's just coming out seems to suggest that the fourth booster does not prevent from Omicron very, very well. What do you think is the strategy there?
I think, number one, a proper mask worn properly, mandatorily enforced. Number two, and I know what I'm saying is unpopular, mandatory immunization. Vanderbilt Medical Center mandates a booster. And we need, as I say, a variant-focused vaccine in order to more adequately protect against Omicron and whatever's next.
Very good. When we look at the differences that you noted between Moderna, for example, and Pfizer, is there anything that we understand in terms of why one is more effective than the other?
Yeah, that's
And
a great
can we
question.
learn in terms of creating new vaccines?
Yeah, that's a great question, Alex. I think the higher dose of Moderna served it well at the cost of increased reactogenicity. And this may be the bigger factor, the 1 week longer interval between doses. For all vaccines, Shingrix may be one exception and the only one we know about. The longer the interval between doses, the better the immune response. Of course, at the cost of until you get all your doses, you're not fully protected. So there's a tension there.
Thank you. A lot of questions coming in. So maybe I'll start with one that is probably the most provocative and the hardest to answer.
Okay.
Boosting versus broadly vaccinating. Omicron seems to have arisen in a different country, on a different continent, and whether it's Zimbabwe or South Africa or Switzerland or Japan, if the world population is not vaccinated, are we safe even if we have strain-specific vaccines?
It's a tough question, but it's a very fair question. And let me answer it. I could care less about politics, so I'm not going to be politically correct. That doesn't serve science well. The old saw is true. Until we are all safe, no one's safe. And absolutely, Africa is only now just getting to 10% immunization rates. There are a lot of reasons and proposed solutions for that. I'm just pointing out that with the unprecedented amount of movement of humans and materiel in this century, in this decade, in this year, that yes, these variants will spread very rapidly worldwide, including in our own country, where we have so relatively few people immunized and where people are not wearing masks.
Thank you. One very practical question that has been discussed many times, but I think it's worthwhile revisiting. Question about masks, surgical masks, N95, KN95. Any advice in terms of relative protective power?
There's no question that an N95 mask worn properly is the best mask protection. I don't know about all the listeners. They're uncomfortable for me. I can't wear them all day. The next best is a KN95, being sure that it's not a counterfeit one and that it does not have a valve. The next best is a surgical or paper mask. The least effective are cotton masks. And the key, as I always say, is a proper mask worn properly, above the nose, below the mouth, with no gapping. When you go to inhale and talk, you can tell whether somebody's wearing a surgical mask properly. It will contract in a bit because of the seal that's been achieved.
I thought this was a hard question, but there's one even harder, I think. Somebody asked, what can we as health professionals do to impact and change human behavior?
It's really hard. I mean, why do I do what I do, even though I know how ineffective it is for the public? Well, a few reasons. I'm inherently an educator and driven, and I think as physicians, we all are. Number two, the chance to save one person is worth it. And I do get cards and letters and emails from the general public thanking me and saying they changed their mind. I really think the real answer to this is changing our society by changing our education system. People do not understand probability. How are they possibly going to interpret the data? They are what are called innumerate, the mathematical equivalent of illiteracy. They do not understand the scientific method. And so they're prone to every snake oil salesman that comes along.
It's really advocacy and being present.
Yeah.
Another question that came repeatedly relates to the mix and match of the vaccines. Any thoughts about that? Any cautions?
No particular cautions from the mix and match strategy per se. Like everything in medicine, if you told me, I had this horrible side effect and I got vaccine A as my primary series, what should I get as a booster? I would modify. But in general, what the data shows is that a heterologous boost is better. Something along the lines of what we would call hybrid immunity, whether that's from infection, a booster, whatever.
So that's an interesting question and raises another one, actually two questions. One, actually several listeners asked a question relating to humoral versus cellular immunity. We measure antibodies. We don't have readily available tests, clinical tests to measure T-cell immunity. And yet, traditionally, we think of viruses as primarily being targeted by T-cell immunity. The question is there anything going on in that space in terms of understanding who may be better protected, even if the antibodies are dropping?
Yeah, those questioners are exactly right. And as you point out, Alex, the problem is we do not have validated, routinely available clinical tests for T-cell subset immune parameters. That actually is coming and will come, but we don't have it yet. So antibody is valuable in terms of infection blocking and therefore preventing disease. But once infection happens, it is really the adaptive cellular immune system that protects us and resolves infection and disease.
Excellent.
And those are well maintained, I should say, in relation to vaccine. The waning I'm talking about relates to antibody.
Thank you. A couple other questions focusing on types of vaccines. And I know you have personal interest there and some efforts in alternative vaccine strategies. Spike protein versus multiple proteins. Are multiple proteins on the horizon as mRNA or protein-based vaccines, and how far out?
Yeah, so very early on in the pandemic, I published an editorial called SARS-CoV-2 Vaccines, the Tortoise and the Hare. And it was roundly panned. None of my co-workers in the field believed what I had to say and kind of dissed it. I wish I had been wrong, but I've turned out to be right, that S-only vaccine approaches are the Achilles heel of these vaccines. We would never take a single antigen vaccine against a highly variable RNA virus. And so I think next-gen vaccines will include more than S protein. Those will be second-generation vaccines. They'll include whole protein, perhaps different adjuvants. Third-generation vaccines are going to be oral and nasal spray, maybe even transcutaneously administered vaccines.
Interesting. A couple of questions coming in regarding the immunity driven by the infection versus immunization. And you showed nicely in your slides that people that have had COVID and had immunization had better protective immunity for longer. Do we know whether, in light of the fact that Omicron is not, infection is not prevented, or severe disease not as well prevented as Delta or the original, do we know whether Omicron infection prevents better, further, or repeat Omicron infections? Is there any data on that?
Yeah, I think it's too early to say anything definitive. I will say for those that are interested, yesterday's MMWR, you can subscribe to that free electronically, comes from CDC, does take a first glance at sustained immunity protecting against Omicron, Delta, and I guess it was just those two variants they looked at. I think that remains an open question. If you survive the infection, does it boost antibody? Yes. Does it boost T cells and resistance against disease? Yes. For how long and to what magnitude is the question? And if you will, at what price?
Yeah. Another practical question that's been asked over and over is, I've had COVID. How long after COVID how long should I wait to get my booster?
Well, that's a really good, as you say, practical question. The original guidance was 90 days later, and the reason for that is immunity didn't tend to wane until that point. I still think that's a good general, thumb in the wind kind of answer. But what we can say is that it's safe to receive it as soon as your symptoms of COVID resolve. What would I personally do? I would probably wait at least 30 days if I had a normal underlying immune system. I wouldn't wait that long. If I didn't, I would try to boost my immunity as high as I could.
Very good. So repeated questions coming in, and I think if I distill them all to this is, do we expect at any point, is there any active work in developing strain-specific boosters? And if
Yes.
so, how far out is that?
Yeah, so both Moderna and Pfizer have created an Omicron-specific vaccine platform. They believe they will be testing that by March. So the question would be, how long before they would have that data? Will Omicron still be around at that point? And what will be the regulatory pathway? Will FDA simply consider that a strain change, much like we do with influenza, and not require prolonged large clinical trials? I think they won't require that. So conceivably probably by summer, if not fall, we'll have probably before fall, we'll have a variant-focused vaccine.
And a lot of questions regarding the general necessity of the fourth booster and whether particularly healthcare workers, and particularly at Mayo, do you envision any strict process to enforce additional boosters? And will we do that annually thereafter?
Yeah, I can't speak for Mayo policy because I don't think a policy has been devised yet. We're all still learning about Omicron. Let me go back a bit though, Alex, to say that second booster, if you will, a fourth dose, does raise antibody levels. In fact, it raises them about 5-fold. So it does work in boosting antibody. The problem is in the face of Omicron, which reduces that neutralizing ability by 40 to 100-fold, that boost isn't enough. And that's why a fourth dose may not be as valuable. Would there be exceptions? Somebody who did not have a healthy immune system, maybe somebody older, possibly for healthcare workers. I find that one a little harder to get to in my own mind. I think it's going to await a variant-focused vaccine. Now, another thing that could happen is that, let's say we have a new variant that has still has high transmissibility like Omicron, but reverts to something more virulent, but doesn't escape neutralizing antibody as well as Omicron does. Then a fourth booster dose might happen. In regards to your question about annual booster, yes, I think we're going to find ourselves there. Moderna, for one, is already announcing that by fall of 2023, they anticipate a combined influenza and COVID vaccine. Possibly what will be added to that in the further future would be RSV.
Thank you. So in this answer, you also touched on different populations, elderly, immunosuppressed, and so on. And you also showed that there are differences in your talk between different people in terms of antibody levels, at least. Do we have any guidance or any firm data yet to start devising approaches that are going to be different from, universal, we're all equal? Do we approach people that are immunosuppressed differently? Do we approach elderly? Is there anything that we can use to guide that in terms of frequency of the boosts and so on?
Interesting you should ask me that question, because I devised an area of vaccinology that we termed vaccinomics, which included the idea of individualized or personalized vaccinology, much like you do in your practice, Alex. We try to personalize and individualize based on factors we know will impact outcome. I think we very much should move that. It's hard in the midst of the fire we call a pandemic, but we've already done it to some degree. We have recommendations for different vaccines based on age group, different doses based on underlying medical condition. I think that trend will continue.
Thank you. And summarizing again, a few other questions. As we think, as we look at this movie, as you said, playing for the 5th time, there are many aspects that are outside of the control of vaccines and being able to really immunize. But if we focus on vaccines, even with the great success that we've had with the initial vaccine, it's clear that human behavior will drive new variants, and vaccines may not work. Is there anything in terms of systemic approach to vaccine development that can make us more nimble to adapt and introduce new vaccines as the strains change?
Yeah, that's a very thoughtful question, Alex. I would say two things. One is we have seen the ability of the FDA to shorten the regulatory pathway in a manner that did not compromise safety, i.e. it worked. So I think we have that on our side. I think the second thing, just like we're doing with influenza, and my lab is working on with COVID, is the development of so-called universal COVID or influenza vaccines. And I think that's the long-term answer. Not kind of the whack-a-mole chase each variant, but rather a vaccine to the degree that we can predict would cover all of the variants that we might expect. That means more than S protein and building immunity against invariant portions of the viral genome and protein.
Thank you. Question also that you mentioned animal reservoirs, and you mentioned white-tailed deer.
Yeah.
I guess the questions could be summarized as what animals? Is there something that we need to be particularly careful about?
Well, let me just say that in my own research, I use mice and hamsters. You may have heard about the hamster outbreak in Hong Kong, and they had to cull something like 2,000 hamsters. So those are clearly infected. White-tailed deer in the US are infected with SARS-CoV-2. They don't seem to have the clinical illness phenotype that humans do, but it parallels the prevalence of infection in the local population. We do not understand why. Why is that important? Because it, number one, says there's an animal reservoir, and number two, the phenomena of so-called reverse zoonosis, where we got infected from a bat-derived coronavirus. It now multiplies in the human population and changes, moves to deer, multiplies through deer, mutates in ways that might not have happened in humans, and then transmitted back to humans. But we don't understand why the deer and how the deer are getting infected.
Very good. I think we will wrap it up here. I'll just ask the very last one for you. 30 seconds message of hope.
So this was the glimmers of hope. Number one, for all of us that don't want to be infected, a proper mask worn properly with properly administered vaccines in a booster and where appropriate physical distancing works, and it works spectacularly well. Not perfectly, nothing human made does, but it works spectacularly well. I.e., I would not go eat indoors in a restaurant. I would not go to a concert or something like that. You're just rolling, you're playing Russian roulette, to use a phrase. The other thing is that Evusheld, a combination of monoclonal antibodies that can be administered every 6 months, looks to be highly effective, including against Omicron. We have rapidly developed monoclonals. There are 2 oral antivirals that are coming very quickly. They have their limitations, and I didn't go into those, but all of those are glimmers of hope, I believe.
Thank you. Thank you very much, especially for that last part. And thank you for being with us today. I can tell you that just by looking at the number of people still present, which is over 200, still
Wow.
15 or 18 minutes after we were supposed to end, gives you a hint of how important people find this topic. Really
Well,
appreciate your expertise and your time that you spent with us.
thank you, Alex. It's a privilege to be able to share, as we all do at Mayo Clinic, our knowledge among each other. And thank you for the honor.
Thank you. And thank you, everybody. We will see you back in a week. Bye-bye.